Well, so we've got a panel. We might have another stretch of some dimension from our chairs and otherwise. We will then have 2 presentations and then we'll hurtle on into a fabulous lunch and on into the afternoon's events and then on into the very excellent networking event, which will all happen on this level. Over lunch, this room's going to be split into rooms and to give you options to go to workshops and concurrent sessions. But without further ado, I'm going to throw now to Shannon Harwood for a panel on, and they're considering what does equally well look like in practice. Love the practical. Over to you.
Hello again, everyone. Yes, that worked, and I'm not going to drop my water, and this section is going to be a whole lot of fun. And I say that because the title for this panel is Equally Well in Practice. So, when I spoke this morning, I spoke about changing systems. In Russell's talk, he obviously presented the evidence of why the systems and current practices maybe need changing. And so here we have with us today people who are actually doing this change in various levels. And one of the interesting things about our panel now, which you'll pick up as I do the introductions, is where our panellists are coming from, because they're coming from all different sections and places and perspectives, and yet they're all connected here in the Equally Well network. So I'm just going to do a very quick introduction of our panellists. Their CVs say a lot more interesting things than I'm going to introduce, but I think we'll be able to pick them up during the conversation. So just going to give a super quick introduction, and then I think I might ask each panellist as I do this just where they first became aware of the Equally Well network and maybe how long they've been in this family. So first sitting closest to me, this is Trudy Brown from Victoria, who's a mental health nurse practitioner with 20 years experience doing fabulous things with physical health. And I'm not going to pre-introduce them because we'll get into that. Trudy. Hi.
Hello. I heard about Equally Well at a conference very similar to this back in 2019, and I thought, oh, that's interesting. I'd like to do stuff on physical health because I've had enough of trying to save the world with mental health, and I can do a lot more good as a nurse practitioner looking at physical health. So that's where I heard about it, and that's where I dove right in.
Fantastic. And I should have mentioned that, Trudy, you're currently working in inpatient units. Yeah, so I should mention the environment there. Because our next panellist is not working in inpatient units. Our next panellist is from Central Eastern Sydney PHN. This is Chris Jones. So he's been involved at the level of policy, servicing, commissionment and leadership across social work, mental health. Chris, where did you first learn and come across the Equally Well network?
Yeah, thanks, Shannon, and hi, everyone. So it's been a really great question to reflect on because where I first heard and came across Equally Well was probably back in 2018. So just come off the back of working with what I think of two of the most groundbreaking mental health programs for people living with severe and persistent mental illness. So that was Partners in Recovery and the FAMS program. So many here would be familiar with those programs. And they did a lot of amazing things in regards to closing the gap of a lot of the areas that people experience in the intersection between psychosocial need and mental health. So housing, the justice system, employment, and obviously clinical need as well. But one of the areas that I saw a massive deficit there for that population was physical health. And, we were able to make some inroads in the work that we did, but what was really lacking was a national framework. And that was what was so encouraging to see when Equally Well came on the scene is that's exactly what was provided. We had something that we could follow, we could build upon policy, we could work together in a collegiate fashion, and resource the sector towards system improvement. And that that work's sort of continued in the work that we continue to do in PHN land and for all of the work that people in this room continue to do. So yeah, that was probably my first intro there, Shannon. So.
Ooh, thanks, Chris. And we're going to be asking you a lot more about what Equally Well looks like in PHN land. That's cool. Our next panellist is Albert Abiola. Now, so inpatient, PHN. Albert's working in public and community services up on the Gold Coast, but he's also, as is Trudy, doing a PhD. So Albert's an early career researcher looking specifically at social connection and the interrelationship there between physical and mental health. Now, Albert, I don't know which year or what it was that attracted you specifically to the Equally Well. I mean, I can see the confluence of interest there. But what was it? When did you first come across the Equally Well?
Thanks, Shannon. Hi, everyone. I came across Equally Well, I think it was back in 2022, and that was through the Gold Coast or the Queensland Health Mental Health Clinical Collaborative. So it's a group of clinicians within Queensland Health. I think Professor John Allen actually contributed significantly to this group when he was back with Queensland Health. And that was when they spoke about the national consensus statement. And I think they spoke about the mortality gap between healthy Australians and people with severe mental illness. I think because of my lived experience as well, personal and professional, that then sort of informed me to complete a quality improvement project where we utilised a lot of the Equally Well resources. And more recently, we just started a physical art project on the Gold Coast. We just developed a multi-morbidity framework and a lot of resources from the Equally Well, specifically the Equally Well framework. It's been very, very instrumental towards our framework.
That's fantastic. Thank you, Albert. So now we have inpatient, PHN land, community and public mental health services. And our last panellist today is Ben Wells from NEMI, looking many things over the course of your career, which you can reference up, Ben, but specifically psychosocial services. And NEMI is a national organisation, so Ben has a broad scope, not only in the development of programs, but in the implementation of them as well. Ben, when did you first come across Equally Well? No, it's not good.
Thanks, Ross. Good joke. Mine's a little bit simpler, I think. My first kind of introduction to Equally Well was when I started at NEMI sort of 3 years ago. Started working with the psychosocial teams, which were sort of really predominantly using health promotions and the health prompts, which I'm not going to ruin too much today, because we will save it for tomorrow. But the conversations and the work that people used and the focus that they had throughout all aspects of the services, focusing both on the mental health but the physical health, and the introduction to that, and as we unpacked it more and as I kind of got into it more, kind of really seeing what Equally Well was and how influenced and the correlation with NEMI and the partnership with NEMI and Equally Well together.
Fantastic. Thank you, Ben. And it's interesting to hear you say that you've just linked up physical and mental health was really what was crossing your services. And when we look at what people are doing in different spaces, I guess everyone has a different place and scope where they're able to act. And I can see in all sorts of different ways, from resources to frameworks, where people have engaged. Perhaps I'd like to start with you, Trudy, because I'm really interested, because when you look at an inpatient ward, in some ways you'd think, well, hang on, there's less scope. In the questions from the previous session, it came up, some of these things it's really difficult to do in an acute setting, but you work in that setting. Tell us, how did you begin? How did you find it? How different was it for the system that you were working in?
So I've been a nurse practitioner now since I think 2012, and when I first started, I've always been on the inpatient unit. And I first started doing like the basics, the seclusion reduction, the things that we were doing badly, with the big gaps that we had in our service and stuff. And then I sort of, over several years, I realised that, yes, I was helping to plug some of those gaps, but there were still a lot of gaps in our health service around the physical health stuff and things that we weren't doing, and hearing about Equally Well and stuff that we could be doing better. And I was like, well, I'm a nurse practitioner, I can do more, I can start helping people with pre-diabetes and cholesterol issues, and then it just sort of snowballed from there, and started having conversations with people who are acutely unwell and needing a hospital admission. But as soon as I start talking to them about physical health, they are very open about the struggles that they're having, the issues, the barriers they're facing. And I was like, well, okay, well, I'll start doing this, and then I'll go train and I'll do more, and heard about Hep C treatment, so I started doing that. And sexual health is a huge gap in services, and so I trained in sexual health, and now I'm giving, helping people with contraception and Implanon insertions on the inpatient unit. I'm doing pap smears, and it's just, what else can I do to help fill some of these gaps and in services and increasing equity and reach? And I had a young girl wanting her Implanon removed because she was having horrific side effects, and the GP wanted to charge her $200 to take it out of her arm, and I said, that's okay, let's just do it now. And it was all free, and it was trauma informed, and it was what she needed at that time in that health service. And her mental health, to me, that's not a barrier in our service. I do what I can with the resources I have and the training that I have. And if I'm not trained in something, I'll go get trained in it.
And something that you mentioned there is really interesting, because you mentioned the conversations that you were having with people. So I've been in that place, in a bed on an inpatient unit, and sometimes there's this sort of perception from the outside world that when you're in that space and that place, that's all you have headspace for, is those mental health difficulties or symptoms. But really, for those of us living with these kind of conditions, it's sort of a continuum. It's not like I was perfect on Friday and now I'm dreadful on Monday. So for people who aren't familiar with that inpatient setting, how were your conversations received by people when you started talking about physical health? Were they saying to you, look, Trudy, I'm really, really sorry, but I'm here trying to deal with this and I don't want to know? Was that what was happening?
Rarely I get that response. Very rarely. A lot of the time it's, oh, cool, you can do that here? Oh, fantastic. That's something I've been putting off for ages. Can you help me with that? It's very rarely that I've got too much going on. I can't talk to you about it now. And that's okay, because that's your choice. I'm just offering a service. If you like it, I'm here. If you change your mind in a week's time, I'll still be here.
That's fantastic, thank you, because I know that Ben, I think, will be talking to some of these issues with the NeMind prop about how do we approach conversations with people about physical health and make those conversations of care rather than sort of tick a box in inappropriate ways. Albert, I know, like, you're working hands-on on the ground there in the Gold Coast. So what activities are happening there? What activities on the actual nitty-gritty on the ground in the Gold Coast? What have you got going on for consumers up there?
Well, we've actually got so much going on. Before I start talking about what I'm involved in, I'd like to highlight that we've got a metabolic clinic, and we've also got clozapine clinics that closely monitor the physical health of our consumers. But like I said, in 2022, when I joined the Mental Health Clinical Collaborative, that was where I saw much about the life expectancy gap, and I think I was mind blown. And I think for someone like myself, was very introspective. I sort of thought about the quality of care we're providing to our consumers. And because we treat a lot of consumers under the Mental Health Act, they're compelled to sort of adhere to our treatment recommendations, things like that. But as a social worker, we're very, very big on, social justice advocacy. So I sort of thought, how can I actually support these people who by law have to adhere to our, recommendations? So that was when as a team with my colleagues, we then decided to start a project. Luckily for us, we had the support of the Office of the Chief Allied Health Officer, and then supported myself to undertake a knowledge translating knowledge to practice course. And in the course, we had the opportunity to explore knowledge practice gap. So as a team, we sort of came together and then utilized a knowledge to action framework, which is an implementation framework developed by some professors in Canada. And the framework actually helps to identify the knowledge practice gap. And I think there's about 7 steps to actually incorporating the implementation strategies into practice. So we identified the barriers and facilitators to, management of physical health. We came up with some implementation strategies. The executive of Gold Coast Health did support us with a lot of the implementation strategies. So there was a lot of education for clinicians. We had physical health champions that sort of supported, team members with ensuring they were monitoring the physical health of consumers. I digress a little bit to talk about what Queensland Health is doing. I'm so pleased Julian is here. So Julian and I have sort of participated in a few working groups on a multi-morbidity quality improvement strategy developed by the Office of the Chief Psychiatrist of Queensland Health. And they've got about 8 different physical health initiatives to actually develop cascades of care for clinicians to confidently manage the physical health of consumers. So Gold Coast Health has been playing a very, very massive role in this body of work. As a matter of fact, 2 days ago, we actually got approved for a grant to sort of liaise with University of Queensland, Health and Wellbeing Queensland, to actually conduct a lot of training for staff on the Gold Coast.
That is so interesting because this morning and throughout it, and Trudy has just said to me now that she went and upskilled in the sexual health, and you've just said it about knowledge gaps and identifying those and then skilling people to do them. It's a little central thing here, isn't it? If what we have needs to change, then identifying those gaps and then upskilling people to do it. So it's interesting that you've both mentioned that, predominantly at the start of what you've just spoken about there. Ben, I'd like to throw it to you because I don't have a complete history of NEMI in my head. So when we're looking at physical health and what's happened in NEMI and how that you've brought that in more to your service, how did that look for you with knowledge gaps and upskilling and taking that on board?
Yeah, I think that works now.
And why did you take that on
Yeah,
board?
I think as across the board, if I can focus on psychosocial, which is probably where I come from, what was being said, it's kind of flipped on the head a little bit in that we really start with the individual, and our role is to support the service navigation part of that. And so we're not necessarily the experts in it, but the knowledge translation and the upskilling is for our role and our team's role is to help navigate through those systems. And so rather than kind of working in the system, we can kind of connect with points of it. And we've got the really unique opportunity of both the community-based workers that have experience in that, but also bringing the lived experience workforce into it. Having a lived experience workforce that have got the knowledge and the experience around sort of physical health and mental health experiences to help navigate is really, really powerful. And working and centering the consumer in that kind of is really central to what we do. And starting with working out what matters to them, what's important to them and what they want to work on is really, really kind of where we start and move from there. So rather than working on a specific need or kind of a particular intervention, it's kind of breaking it down a little bit, simplifying it a little bit more for them and starting with identifying what's important to them, how do we kind of support them, and then kind of building on that as we go and using things like the health prompt. But that is really essential for us because what that does is really simplify and kind of bring everyone to a place where it can be a discussion point. It can be a place where it's really driven by that person to sort of identify what is it that they're wanting to work on, what speed is it that they want to be working towards that, and build that relationship. And so we can find that collaborative approach. We've got the advantage of working a little bit longer term, and so it's not necessarily just walking in and walking out, but we can work with someone, build that rapport, build that understanding, build that trust, and so we can unpack it as we go as well.
And what you just said there, because you were saying, you were person-led, so you were asking. So I'm going to ask you something a little bit similar that I asked Trudy. So I'm guessing that if you're person-led and people are bringing these things to you, because when I spoke, I sort of spoke about that, turning the blind eye to something. But it sounds like the people that you're working to are bringing to you physical health concerns. Is that what you were finding?
Yes, and I think what we do is we try and open that door as well. And so similar to the conversations I think Trudy was mentioning is sort of people coming in saying, this is just what I want and I haven't got time for anything else. Or they're coming to us with the understanding or through a referral, kind of, I'm here to work on this one thing. If we can sort of open that door, open that conversation, yes, but are you interested in doing this as well? What does that look like for you? That helps us kind of progress. And so for the individual, there's still choice and there's option there, but we're able to introduce it to them and sort of leave it with them to kind of dictate where we go.
Yeah, cool. And you're finding that once that door is open, people are interested.
Definitely. I think you spoke really clearly this morning about the barriers and the challenges we've got across the board with accessing different things, and I think that opening, that hope, I guess, so that kind of that light to kind of go, yeah, I can actually kind of do something here. We see people really kind of buying into that.
Chris, now I sort of feel sorry for you as I pose this question to you, but we've just heard about 3 people across 3 services where things are starting to work a little differently, where things are perhaps starting to work in a way that they have not necessarily worked in the past. I certainly didn't have a nurse practitioner asking me, was I up to date with my cervical screening, So these are new initiatives. So you're sitting at the service commissioning here in the PHN. How does the PHN look, deal, interact, either respond to services are changing or from the PHN perspective, create a situation where new services can come in? How does that work?
Yeah, thanks, Shannon. So for those that probably just a really short, sharp context for people that are unaware of how PHNs function and kind of the mandate that we have from the department, is that probably the first thing is that we need to have a really deep and innate understanding of the regions that we serve for mental health need. So that's always where we start. That gives us the opportunity to do fantastic things like co-design with the communities that we work with. So we get out there and talk to people about what they're experiencing in regards to their mental health need. Obviously, we support that with really strong and robust needs assessment as well to make sure that we've got the deepest understanding possible. And again, it gives us the ability to put together models of care. So I think when we apply that to the opportunities that we have for physical health, that's where we've seen some really fantastic change, particularly over the last 10 years. So the 10 years that the PHNs have transitioned from Medicare locals. So to give you an indication of how that kind of plays out in real time in the area that I work in, Central Eastern Sydney. So that type of work, from co-design right through to model development and service delivery, has led to unique programs like a GP and mental health shared care approach. So we'll be presenting on that a little bit later today. And that involves clinical nurse consultant positions in LHDs, obviously working with people with severe and enduring mental health problems, but making sure that they're not just matched up and have regular support with GPs around their physical health, but again, as Ben Trudy and Albert was saying before, that the consumer's actually leading that work as well, and they're having a say what that looks like and what physical health should mean to them. So we're in the process of, we've recently had a redesign around that program, so we want to make the consumer voice more prominent. We want to make sure that physical health stays a priority, but coming back to kind of Shannon's question around the change that PHNs can exercise, is that we add capacity in the sector. Again, we're at a really unique, we've been given a really unique mandate that we can bring physical health, primary health rather, and tertiary health together. And we've actually got mechanisms to do that. So my counterpart that's with me today, so Phoebe in our PHN heads up our regional plan approach. And again, that's something that the PHNs have had in place for a number of years now, where we regularly get together with our tertiary counterparts and we plan together. So it's moving away from that siloed aspects of something happening in primary health over here, something happening in tertiary care over there, and those not meeting in the middle and having mechanisms to do that. So like I said, we bridge that gap through programs like our shared care approach. Like Albert said before, he has things like clozapine programs in his area. Again, we work together on those programs there. We've got other programs where we fund and bring together allied health professionals, obviously working with mental health professionals as well. And again, we've got a mechanism through regional planning, through needs assessment and through co-design that not only helps that to happen, but it gives it the ability to have some continuous improvement as well. And look a few years down the track to make sure that we've met mental health outcomes, physical health outcomes, and again, we can look at, importantly, whether the consumers actually had a say throughout that process.
Thank you, because it's interesting, isn't it? When we look at the Equally Well consensus statement, and the first point is holistic and person-centred care. But it seems to me that, and I was talking about separation earlier. It seems to me that offering the kind of holistic care that we're hearing about must come with its own challenges as well. You've just talked about, crossing primary and tertiary, and you're talking about crossing. And I'm curious about this in terms of, because, we're an organisation that wants to move forward and continue, and people tell us, where's the evidence base? So I'm really curious to hear from all of you, because I think you're doing it in different spaces and ways. So I might just start with you perhaps first, Trudy. But so if you're working as a mental health nurse practitioner on a mental health ward, and let's say I'm your patient, right? And I want you to care for me and look after me and make sure that the medications that I'm using or taking are administered and my needs are met, right? But when I walked in to your unit, I wasn't really expecting to be able to book my mammogram and, and have my blood test taken and for diabetes and these kinds of things. So now that you've done it, how do you measure it so you can grow it? And because I think, we haven't spoken about in the room yet, but you also do a significant role in education. So how do we take what's happening and then evaluate it, measure it, report on it, or educate about it?
So I do a lot of these type of talks, and I did one a couple of weeks ago, and I'd done a snapshot audit of the patients on one of the units I work on, and I'm working on a women's ward at the moment. And we've got 25 women there, and what I presented was some statistics around just cervical screens. So I use cervical screens as a road in to a lot of my conversations with the women on the ward, because it's a national registry. And we had 25 women admitted to this ward, and of those 25 women, I think 19 were eligible for cervical screening. So to be eligible for cervical screening, you need to be over 25 and you need to have been sexually active at some point in your life. So of these 19 women that were eligible, only 2/3 of those women were up to date with those cervical screens. So fantastic. But we still had a third of the women, so 6 or 7 women who were not up to date with their cervical screen, or they'd never been updated. So I went and approached those women and said, look, I've just noticed that we can assist you with this physical health screen if you'd like. Gave them a bit of education, and 5 out of those 6 women agreed to do their cervical screens. So instantly we got the numbers sitting from 2/3 up to almost 100% completion of the cervical screens just from that one little intervention. So I've just put in a protocol with my health service to try and get that written up as a research paper so that it can get published out there, because it's just me as one clinician have suddenly increased our cervical screening rates through the roof compared to what they would be if I wasn't around. So I see benefit in that sort of sharing those stories and getting other people invested in this, because it doesn't take much to go train in cervical screening. As a nurse, nurse practitioner brings added benefits, but there is nurse cervical screeners out there, and it's a great initiative that we can get those screening rates up. And then those conversations lead into other conversations such as, well, you're also eligible for breast screening. Have you had your breast screen? Come and have a sit, we'll have a chat, let's set up an appointment for you. There are barriers to getting appointments with Breast Screen Victoria, but that's something that we can work through together. So it's just starting these conversations and then sharing and spreading this word and empowering other clinicians to take this up. This is not hard work, but it takes someone to go, okay, that is a gap in my service, I'm going to pick that up and run with it. And then I'm doing a PhD around how can we actually set up a framework so that other clinicians who haven't had the training then know where to go. to help and direct their patients to this sort of service as well.
You know, I love hearing about that. I love hearing about the conversations. I love hearing about the stories, but there's a little place in my heart that loves hearing about a hard audit that goes to a protocol, that goes to a research paper, and then is able to filter from the top down and be accessed by others, to be able to spread that. Maybe Ben first. So I imagine that Nimai is looking at outcomes. So tell us about measuring outcomes, specifically in relation to this, obviously, this physical health aspect of what you do.
Yeah, I think I was hoping you would come to me last, but what I was going to say is it's obviously a really challenging thing, and I think there's kind of a duality in my head around it. Is that, you know, the work that we do, we obviously measure sort of what we do in different ways, and so I think if we think about some of the services we run around the health promotions, the work we do, the outcomes we get, you know, what we hear from the consumers around sort of one of the top outcomes around physical health is being linked with a GP, but being satisfied with that relationship. And I think that's such an important piece, partly because of the stuff we've spoken about this morning, but kind of ongoing. The kind of duality, the second part about it is that the work that we do is very kind of, not necessarily targeted, but kind of focused on sort of, you know, mental health interventions or providing kind of psychosocial interventions, and this is the scope. But what that involves is so much more. Like we're doing so much around the edge, or even before sort of coming to the service, like working with people as they're coming in, and what does that look like, and how can we support? And not everyone comes in, but we're still kind of working with them. And that's the stuff, I think, if we think about outcomes or data as a whole, that does get missed. And the challenge for us is thinking about how do we tell that? How do we create the story of that work or capture that? So it can be used, so it can inform sort of commissioning, so it can inform sort of development of staff or services and in information sharing and knowledge gaps. And so I think there's a kind of the individual data and the transition, but service and commissioning and then the overall kind of challenges we've got around how do we tell that work that's kind of implicit in what we do, but not really what we do.
Yeah, and that's the essence of holistic, isn't it? When you're doing person-centred, person-led, there's no point doing person-centred, person-led, but then you have to go down these channels. You need to be person-led, and as you just said there, that's going to bring you outcomes that you may not have been expecting when you began. And, you know, thanks for answering that, Ben. Now, Albert's got an even more difficult one to answer, because Albert's doing a PhD, and Albert's background is actually in psychology, physiology and social work. So again, we're looking at multidisciplinary, crossing the lines. But Albert, your PhD is actually looking at social connectedness in relation to physical and mental health. So how do you go when you're looking at, because to me, you know, have I got a date for Friday night? I mean, is that what we're measuring? How do we measure these outcomes in social connection in a way that what you are doing can then again extend, be picked up, be used? How do we translate that human element into what you're doing in your PhD?
Well, thanks a lot for that question, because it's a very, very important question, and I think it's a global issue as well. Just recently, we completed a systematic review on the role of social connectedness in, you know, the relationship between physical activity and mental health in people with a severe mental illness. And what we found out was just 11 papers contributed to the systematic review, and in 11 papers, they were poorly done. And there was actually no sort of major focus on social connectedness. So we actually were able to confirm that there was an evidence gap around. People are not even looking at the benefits of social connectedness. Like I highlighted earlier, a lot of what I'm currently doing is from my lived experience, my personal experience. I'm very, very introverted. I really don't go out. But I go to church and I play football. And I know one of the reasons I probably am able to juggle so much is because of the social connectedness I benefit from playing football. And I know for a lot of our consumers as well, the research is actually showing, I think there's actually a big debate that it's not even physical activity that's contributing to the positive benefits of, engaging in exercise. That's actually the conversations you have with people when you exercise. There is another debate around, do you benefit more from engaging in physical activity with groups, or do you enjoy doing it, individually? So going back to your question, I think within a lot of services, there's actually not enough metrics or, ways of actually finding out, the outcomes in relation to social connectedness. I'll probably answer a question you did not pose to me around, other areas of physical activity. In Queensland, for example, I know on a 3 monthly basis, there's lots of KPIs we've got to meet, physical health KPIs that we've got to meet. So in the Gold Coast, for the longest, we were not meeting some of those KPIs. But then exec sort of, rallied around myself and my colleagues, and then we've been doing, a lot of this project, and we sort of went from 12th statewide to second in relation to physical health intervention statewide, and with physical health screening, Gold Coast Health is first. So now Queensland Health is coming up with an initiative, the Multi-Morbidity Quality Improvement Strategy, where they're focusing on physical activity, oral health, EPC, alcohol use, and substance use as well. So with that, they've sort of come up with a way of measuring the outcomes. So I'd like to believe that in the near future, we'll probably have ways of evaluating, the benefits from social connectedness. So in summary, we do not have those metrics yet.
Yes. So interesting, isn't it? So here we're going from practical change, like practical hands-on doing things, to going, oh no, something's happening. We're doing things differently, and now things are happening, and now how do we measure that? And I think that, that measuring is really, really important, especially, when you're perhaps measuring things that haven't been looked at in great detail before, or are not expected KPIs from the particular service that you are running, like in Trudy's position. Chris, I'm thinking about this, and I'm thinking, well, at the PHLN level, when you're looking at measurements and outcomes and evaluation, so when you're looking at evaluation, do you see that as driving, I said I do. I believe that those audits and things will then be able to use to drive cultural change. And here we are looking at 4 champions, like these are champions of these issues. What Albert's just said about what's happening in Queensland is inspiring. But in PHLN land, as you call it, Chris, do you see evaluation as helping with cultural change?
Yeah, absolutely. I think probably the journey that PHNs have gone on, not just with physical and mental health, but across the board, what we do in the primary care landscape is moving past just what you see on a page in regards to KPIs for a service. That's obviously a big part of what we do. So, to give you an indication of, kind of how we go about things in, the mental health sphere, obviously we want to see improved mental health outcomes for the programs that we support and fund, and for the people that use them. That's that's imperative to the work that we do. But again, we want to hear the narrative, and we want to hear the story from people as well, so that there are tools in regards to patient experience measures. Some of them are fantastic, some of them are quite limited in what they can provide, but what we've got a lot better at doing when we're talking to services that we fund is getting to the story of what that consumer's actually saying about the journey that they've been on. And to come back to what I mentioned before about the redesign that we had for our GP and mental health shared care program, so that came directly from feedback from people saying, well, for instance, look, we've got these fantastic positions in the LHD in regards to these clinical nurse consultant positions. We know that they're meant to be talking to GPs about, helping to provide a pathway to better physical health, but we really lack clarity in, the scope of what these roles can provide, and how we can have a say in our overall care. So again, we take that on board, and again, it led to a redesign of the service, which we're now at the beginning of hopefully, looking at what the next sort of 12 to 24 months is going to be directly as a result of that redesign. The other one I'd say, Shannon, is probably around capacity and culture change. So I think you briefly mentioned it before. culture change is the one that people will often bring up with a lot of passion and be really genuine in that. When you're confronted with actually doing it, it's incredibly hard to do. And I think physical health is the prime example of that. There's a ton of absolute goodwill at a primary and tertiary level. Again, there's ways to bring people together. It's being able to maintain that. And I was just having a conversation with a couple of colleagues this morning. One of the things which has again come out of feedback and evaluation is involving GPs more effectively, obviously in the physical health care of people in tandem with mental health. And again, in our region, what we're doing at the moment to improve that is a GP incentivisation model. And again, to really ensure that continues to happen for a number of years, that involves system level culture change with GPs, with the primary health system and with the tertiary health system as well. So again, we're going to have to make sure that as we continue to do that, and when we've got some runs on the board, that's evaluated. Because we do have 31 PHNs across the country. We'd love if we do a really good job in Central Eastern Sydney, that model can then be used across the country. And again, with the backing and framework of things like Equally Well to support us, there's a much better chance of that evaluation, that work paying overall dividends. So.
What I want to do is I want to ask you about the kind of education initiatives you'd be doing at that level of culture change, but I'm not going to do that. What I'm going to do instead, I want to, but what I'm going to do instead is I just want to let our four panellists, because you've heard each other speak, so I'm going to open it up to the room for a minute. So if you've got questions and you want to think of them and jot them down, please do that. And we've got help here with mics going and help in other places with roving mics. But first, I just want to let the panellists, having heard that from the other panellists, were there any particular points that you would like to bring up with each other before I open it up to the floor? No, you're ready for the onslaught. Okay. Let's see, would anyone like to ask some questions?
Thank you. Albert, my question's for you. You talked about having those extra physical health KPIs and doing those extra physical health assessments. What's the link then to the person's nominated general practice or GP?
Well, thank you so much for that question. It's a really good one, because what we're trying to do is we're trying to change the way we manage the physical health of our consumers. I think it's going to be very difficult if we identify individual consumers. It's going to take a long time to actually do that work. I think it's also worth mentioning that there's not a lot of allocated time to do this work. So it's sort of in addition to, clinical work. So with the KPIs, what we're doing is if teams and services are sort of mindful of how well they're traveling or maybe not traveling so well, they can sort of make those changes in relation to how they're sort of supporting the consumers. In the education we're providing, because I've been working collaboratively with the education department of the Mental Health Service, we're actually talking about the benefits of collaborating with other stakeholders. It's just not something a case manager can do. So we try to get the GPs involved after every medical review with the registrars or the psychiatrists. We're sort of educating clinicians, case managers, to ensure that they send in the notes to the GPs, and also on a 6-monthly basis for the case manager to make a very conscious effort of attending a GP appointment as well. So we wish we actually have a bit more funding. I was actually thinking about, the possibility of establishing a physical health clinic where we could actually have our own in-house GPs, where clinicians could sort of identify maybe consumers who are not going to see their GPs or at risk of, metabolic syndrome and things like that. So as everyone's highlighted, it's very, very difficult to, one, make change and to be on top of the physical of our consumers, but we're just sort of taking those baby steps.
Thank you.
Can I just say, this is just so fabulous. Whoever you are, who are you? Chantel. Hi, Albert. I'm with the Gold Coast PHN and would be keen to explore if there are any of the GCH, that's you, approaches that we could think about replicating in the primary care space with mental health and alcohol and other drug services.
I'm sure you saw how excited I was.
How good is
'Cause
this?
one of the questions I posed to Chris this morning was actually, how can I get through to the Gold Coast PHN?
Okay, so
Yes.
hello. Where are you? Put your hand up. I want you to clap. Oh, yes, there you are. Hello. So
I'll come find you.
this is the Equally Well speed dating service. You need to connect with you
Yes.
after this session.
This is the Equally Well Network. This is exactly what it's all about. That's
Okay,
fantastic.
so also, hi Trudy, I'm a nurse practitioner. I mean, can I just say, can we just give it up for these people in the middle of your panel? They're phenomenal. I'm a nurse practitioner in a community mental health team in, now look, I don't know acronyms, in fact I refuse to use them, CALHN. Excellent, them. My SOP,
Scope
P.
of practice.
thank you, is EW, equally well. I'm interested to find out more about how you work on your unit. What's the best way to contact you? Regards, Carmen. Where's Carmen? Unless you're online. There you are, Carmen. Trudy, that's the next speed dating session.
Come and find me at lunch.
Excellent. Another question. We've got another question from the audience.
Thanks. I think this is a really good discussion. So I'm a GP, so we've had a lot to chat about GPs and how to connect with them, and I represent the Royal Australian College here in South Australia as their Deputy Chair. I'm presenting with Chris later about how we can collaborate together. One comment I would make is that this is excellent, like cervical screening and inpatient units, wonderful. You know, there's a lot of great services here. My question is, and I'm making an assumption here, but majority of this is in salaried positions with block funding from the government. General practice is fee for service. We're not salaried by the government, in spite of what might have been in the media recently. I won't get too political about that. And there's a lot to talk about bulk billing, which is the thing that's been in the media lately. So I guess, yeah, my comment would be about communication, and I think we've heard about that as well. So I think within the system that we currently have, accepting that, yeah, it needs to be improved, and there's lots of ways we can do that. If we can work on things like using the My Health Record and other communication tools, many of us are still on fax machines, which is embarrassing but true. You know, we're moving to an IT system eventually. So I think the two things we can do is, one, recognise that GPs are doing the best they can in a fee-for-service model, where they're not actually funded for any administrative things like phone calls and letter writing and different things like that. And if people don't turn up to appointments and things, which there's a myriad of reasons for, but essentially that isn't covered by anything from the government. If we can, just appreciate that position as opposed to salaried models, and also, use the tools that we currently have to communicate.
Thank you, and I feel like I should apologise for me sharing my appalling GP services that I've personally received. And, sitting here as a GP and going, I'm keen to integrate, and I know that there's a barrier, communications and correspondence, but still sitting here saying it has to happen and he has to do it. Thank you for that.
Some quick questions through. So I might just throw a few up in the air that have come through on the WhatsApp. Thank you so much if you're joining us online and you're sending via the WhatsApp as well. Sorry, I've got my back to you actually. Sorry, live stream people. Trudy, and we'll just answer really quickly if we can for follow-up discussion. Is that okay? Trudy, from Mari, who follows up on the results? You may have answered this. Who follows up on the results of cervical screens and mammograms? What happens when they are discharged? Not the mammograms and the cervical screens, but the humans. What if they have no GP?
So the cervical screen I offer is a full service. So I will swab or screen on the inpatient unit, and then post-discharge I will actually contact and provide the results. And then if they need a referral for a colposcopy or something like that, I then refer in-house to the gynecology service in-house, and then I follow up those referrals. So just because they've left the doors doesn't mean I don't stop my interventions. I'll make sure that everything's closed up nicely, and if they don't have a GP, I'll encourage them to.
Can we please clone you? Yeah, I'd like that to happen.
It is
science,
impressive.
make it happen. It is very impressive. A question for the panel. Okay. From Harry, I'm curious to understand some of the physical health KPIs mentioned. Follow up from Harry. Something like mandating offering physical health screening for consumers seeking mental health treatments would hold services, PHN and tertiary, more accountable. Thoughts?
Yeah, I can start with that one. So, to Harry's question, we absolutely do have that as part of our KPIs. The actual tool that's used and some consistency around that is probably the battle that we've had over the last couple of years. So it's really timely that the work that the Equally Well team and Russell are doing at the moment with things like the help prompt, that's probably what we're going to look at leveraging, because it's quick, it's simple to use, and there's the ability for quick follow-up and scaffolding services around it. So it's a great question, Harry.
From M, hi panel, why aren't federal government taking the opportunity to increase scope to address physical health in Medicare mental health centres that are rolling out? Any thoughts from anyone? Any thoughts from the room on that? Or would you like to
It's probably a PHN related question. So I think there's scope there because the whole concept of a Medicare mental health centre is a multidisciplinary team. I guess the barrier is there hasn't really been direction from the government around allied health positions, physical allied health positions in that team. They are mental health focused. So again, it's then up to the direction and the relationships that localised team has with the other professionals and obviously GPs as well to do that. So I think would absolutely encourage it, but needs some direction and some ability to branch out and have a go at it from the department to those Medicare mental health centres.
And a brief comment from Russell.
Yes, some of them do. So I do understand Mount Barker Medicare Mental Health Centre has an Equally Well practitioner, and I also understand Stride. Yay!
Where are you? Hand up. Mount Barker, represent.
I also understand Stride, I think, has got the contract for about the other half in Australia, and they're very interested. So a lot of it is about advocacy from us and Equally Well, but we are all equally well. So we're really hoping that the Mount Barker model could be evaluated and rolled out nationally because we think it's awesome.
That's great.
Who would like a speed date with the Mount Barker crew? Hands go up. Yes. Is that a question from you? No, that was a hand. That's okay. Speed date between the Mount Barker woman in blue dress, and there's a question in Hang on. Oh, sorry, I just stepped on your foot. That's not good, is it?
I would just like to echo from what my own experiences and what I'm hearing around the traps about the physical side of things in the mental health centres and stuff like that. We're not all there yet, but I think we are very much heading in that direction. I think it's just a bit of capacity building. At the end of the day, it's just the numbers and a little bit of time needs to move, but I think we are moving in that direction.
That's a beautifully positive statement. And Rita writes a question for the panel, and then I'll come back to Shannon to round off, because I think you had some other questions that you might want to ask. But how has lived experience and person-led practice challenged you and changed your own practice in the mental health field with particular reference to physical health?
Maybe that one might be a nice one to go 1, 2, 3, 4.
Great.
On that answer. So, no, Ben, you weren't expecting me to ask you. I'm going to do... Ben, I started that end of the panel.
Yeah, I think... I don't know. I think that there's lots in that. Ultimately, it's really benefited us. As I said before, I think having peer work, having lived experience in it to inform what we do. I think we talked about co-design and we talked about the work that we do. The more we have lived experience represented in all aspects of our services that inform the way that we do, ultimately benefits and the people using the service users, the consumers. And so I think if we talk about practice as a whole, having that centred, having lived experience centred in what we do informs it all and improves everything that we do.
And I heard you speak recently, Ben, because, obviously you can have lived experience of mental health, but I heard you talk about setting up services in rural areas recently. And if we extended the concept of lived experience to be environmental, so lived experience of people living in rural towns, lived experience of people living without services, would you like to talk to that, about how that changes how you're not only the people who will use your service, but the environment that your service is going into?
Yeah, I think the concept or the kind of the context of that is sort of rather than trying to deliver something to or in a place, we really focus for us in that is delivering it with it. And so the lived experience wasn't just about the consumers or the people using the services, but it was also about considering the kind of the ecosystems, the landscapes, the communities that are in, but particular, thinking about sort of what are the other services, what are the other things being offered, and how can we complement each other, how can we collaborate better. And so, and as an individual, as a sector, as a whole, as organisations, I think that lens has been really, really important to kind of going about how we do what we do.
Thank you. Albert, social connectedness. Tell me about that with lived experience as you're running that and getting feedback and changing and determining what you're doing in your research. How has that shape shifted, changed, inputted?
Absolutely, it definitely has. Once again, I'd like to thank you for talking about your experiences this morning, because as I highlighted not too long ago, all of the work I'm doing is from my lived experience as well. Did suffer a significant amount of adverse childhood experiences. I got into medical school at 16. At 16, I wanted to become a neurosurgeon. I wanted to literally change the world. I got into medical school, my trauma, everything came to the forefront, and I failed. I didn't do really well in medical school. So I then finished with my first degree in physiology. But of course I knew, without being grandiose, I'm relatively intelligent. I felt I could actually do a whole lot of things. But of course, because of what was going on for me, I felt I needed to sort of address that. And as I just continued getting those degrees, I just felt, there was something about me. I needed to explore a very significant knowledge gap. So because as a young person, I wanted to also become a footballer. I was really, really good. But my parents were professors, and that's actually where some of my adverse childhood experiences sort of lied from. But then again, I sort of was able to understand the benefits of going out to play football. I was very different. I've been miserable in the house, studying, but a happy guy when I'm playing football. So with this current PhD, or sort of working in mental health, and sort of heard about the life expectancy, and sort of coincidentally found out the benefits of exercise for people with a mental illness and how it could actually reduce or maybe increase their life expectancy, that sort of intrinsically motivated me to do a lot of this work. Talking about lived experience, we've actually involved quite a number of peer workers on the Gold Coast to sort of co-develop a physical health intervention. Because at the start of my PhD, we sort of came up with what the objectives of the PhD was going to look like. And of course, people with a lived experience are going to be very, very involved in this work. I think at times when we're doing things, it's good for us to get people who have a bit of an understanding of the context, a bit of experience around what is being done, to sort of be involved in the work. So in conclusion, people with a lived experience have contributed significantly to the work we're doing.
Thank you so much. Thank you. And Chris, in the PHN, I'm not sure whether Central Eastern Sydney PHN has peer workers, but I would be very surprised, having heard you speak this morning, that you're not actively engaging with lived experience. How does that look for you?
Yeah, so we don't have peer workers at the moment, but a lived experience workforce is something that we've definitely talked about looking at a PHNs. Other PHNs have that in place. But from co-design right through to service delivery, we always make sure that we have a lived experience perspective that leads that work. It's really, really important to the work that we do. And I'll just come back to, I guess, where I started with, I talked about, years back working in the Partners in Recovery and FAMS programs. And one thing that still sticks with me, we had a really strong advisory committee as part of Partners in Recovery, just with some absolute trailblazers in regards to improving the system for people with severe and persistent mental illness. And unfortunately, due to physical health concerns, a number of those people aren't with us today. So it always brings me back to the fact that that's how profound the lived experience voice is. So the fact that if those people were listened to and those things were enacted within the system, those people might still be with us. It speaks to what Russell was talking about before, So the fact that we've got these lopsided statistics for the rest of the population of people with severe and persistent mental illness, it's an absolute indictment on the system that needs to be corrected, and that's why we're all here today. So, to echo what Albert said, that's how strong the lived experience voice is, and we're always super aware of that from a PHM perspective. So,
thank you very much. There's so much in that, but again, I'm not going to follow up that conversation because I'm curious, Trudy, because working on the inpatient, but now you're off to do a PhD, and I think there's a moment before you're doing a PhD, and then there's a moment when you've begun a PhD, and I can't but help think, when I heard you speak about conversations with people, I can't but help think that what you were experiencing directly with the people that you were working with has shaped that. Would that be correct?
Yes, and I'm also very benefited by the fact that we have numerous peer workers in the inpatient setting that I'm working in, and in the community settings, and consumer advisors and so forth. So even developing the questions for my PhD, we're all run past and collaborated with the consumer network that I'm privileged to work alongside. So they're helping. We're doing I can't even remember what it's called, but when we develop the framework, that's going to be completely co-designed with 50% clinicians, 50% lived experience workforce, because like it said earlier, nothing for us without us. So it's making sure that I've got that lived experience voice with whatever framework comes out of this PhD. And I'm getting the majority of my referrals to see patients are coming from the peer workers on the ward, because the patients are going to the peer worker with their questions and concerns and guidance for navigation. And they're going, hey, we've got Trudy. Go and see Trudy.
I love when a multidisciplinary team comes together. That's awesome. I'm just going to check, look, the discussions have been fantastic. I'm not sure if we've got time for more questions. We probably don't. But, I mean, we've talked about the speed dating. We've talked about connecting in the networking. Have a good look at our panel before we thank them for today, because I'm sure that they'll be very happy to be buttonholed over the course of the conference to talk more about what we've heard. But otherwise, I'd very much like to thank our panel across all levels of the work that they do. I referred to them before as champions, and I'll say it again, because the work that's being done, and by so many in this room, is the work that's pushing forward physical health on the agenda in mental health. So a big thank you for our panel today.